Um, just a little to add a little bit more about myself. I am an engineer. I'm not an MD, right? So this is about healthcare, but I have my PhD in industrial and operations engineering from the University of Michigan. So I am trained in industrial engineering. That's my academic background. Through a weird life course, I have ended up with a tenure position in orthopedic surgery, but also positions in industrial and operations engineering and biomedical engineering at the University of Michigan. And in fact, I teach a course on optimization modeling in healthcare in the industrial and operations engineering department. And I've wanted to have an opportunity to speak at your university for a long time. I've a good friend of mine from many years ago at Ohio State, Mohammed Parniampur, I believe was part of your faculty for a long time. And I always was hoping to get a chance to come and speak in person. That has not happened, but I'm really, really grateful to be able to do it virtually here. And I hope that at some point in the future, I'll be able to actually come visit you in person. So with that, my talk today is about healthcare quality improvement. It is something in America, industrial engineering has started moving into in the last couple of decades. And okay, so I need to control this with a forward. There we go. The first slide is a disclosure slide that is pretty unusual in engineering. You may never have seen this before, but in the medical school, all the faculty are required to include a conflict of interest disclosure at the beginning of their talk. And it's about financial relationships that I have with pharmaceutical, medical device companies, et cetera. And many physicians have those kinds of relationships in America. And the audience needs to know what those relationships are in case they might create bias. So my disclosures are that I don't have any relationships with medical device manufacturers, pharmaceutical companies, or insurance companies. No direct stock holdings or consulting agreements or anything like that. However, 30% of my salary from the university does come from a contract from Blue Cross Blue Shield of Michigan, an insurance company, healthcare insurance company in Michigan, to operate what we call the Michigan Arthroplasty Registry Collaborative Quality Initiative. And the acronym for that is MARCQI, and we pronounce that Marquee. And that's what I'm going to be talking about today is Marquee. I'm co-director of Marquee. So part of my salary comes from operating Marquee. So with that, I'll jump into it. What I'm going to talk about today is a general introduction about arthroplasty, which is really a medical term just for joint replacement. So I'm talking about hip and knee replacement procedures today. And then I'm going to talk about the structure of Marquee, our Quality Improvement Collaborative, talk about some of its successes, and then talk about some of the analytical challenges, kind of the knowledge gaps, kind of the techie engineering part of what do we as industrial engineers can bring to quality improvement in healthcare, but also pose a bit of a provocative challenge to you maybe about asking some questions of where some innovative tools that have been developed in healthcare analytics, where can that fit in the industrial engineering curriculum? It's a challenge that we are facing here at the University of Michigan, and I'd be very curious to hear how you've thought about it and what you've done about this at your university and your curriculum. So let's jump into what is arthroplasty, joint replacement. Here is some x-rays, some radiographs of hips, okay? In the center, you see a healthy hip. You can tell it's healthy because between the head of the humerus, the upper thigh bone, you can see the head of the humerus here. Between the head of the humerus, wrong word. I'm sorry, my brain just did a complete spasm there. The humerus is in the upper arm. I'm talking about the leg here. Femur. It's too early in the morning here for me. Sorry, everybody. You're in the afternoon time zone. I'm in the morning. I'm still waking up. So head of the femur, okay? And that's the circular thing here on the end of the bone. And then you have the acetabulum in the pelvis. And between the head of the femur and the acetabulum there is a joint space. And it's equal space all the way around the head of the femur. And that's where the cartilage is. That's a healthy hip. Now, what you see on the left is a situation where the cartilage has been worn away. There is no joint space between the head of the femur and the acetabulum. And that lack of a joint space suggests a disease called osteoarthritis. And osteoarthritis is painful and it limits the range of motion of the joint. And the definitive treatment for osteoarthritis of the hip is a joint replacement. And that's what you see on the right of the screen. And you can see something that looks like a manufactured thing in the joint where there had been a femoral head. Well, that's in fact what it is. It's a manufactured device. It is an implant. Okay, so what I was talking about, so here is the head of the femur. This is the acetabulum. And between the two, I'm going to get fancy here and do blue. That's the joint space. Okay, that blue, that joint space represents a healthy hip. Okay, and then over on the left, you can see there is no joint space. Okay, that's the indication arthritis. And so the definitive treatment for osteoarthritis of the hip is putting in this implant. Okay, thank you very much for that, showing me that tool. Cool. So what we have is a schematic here of a hip implant, and this is called a conventional hip implant. It's the most popular one that's used throughout the world, and it involves a cup that goes into the pelvis and the acetabulum. There's a liner, then there's a head, and there's a stem. The liner is usually plastic, but sometimes it's ceramic. The head is usually cobalt chrome steel, but sometimes it's ceramic. But this is basically the pieces of a hip replacement. A knee replacement is shown here in an X-ray, okay? And it typically has two metal pieces, a piece that fits on the femur and the piece that fits in the tibia. And then there's a piece of plastic between the two, and the X-ray goes right through the plastic so you can't see it. So that's basically what a hip and knee replacement is. And in the United States, a lot of these procedures are done. I mean, a lot. The y-axis on this is in thousands. So when it says 1,000, that's 1,000 thousands or a million. Okay. This projection was done back in 2007, but it's actually been really on the mark. They did a really good job of projecting. Out in 2021, where we are, we're doing in the U.S. over 1.5 million knee replacements a year. Okay, and almost 500,000 hip replacements a year. So in total, it's about 2 million joint replacements, hip and knee replacements total, done per year in the US. That's a lot. It's a lot of people. It's a safe procedure, by and large, compared to other surgeries. It's a very safe procedure. But even though it's safe, bad things do happen. They can happen. So here's a list of some of the bad things that can happen. Patients can die during the operation. It's infrequent, but it's between 0.1 and 0.2% of the patients die. Infections are between 0.5% and 1%. And I just want to focus on this, say, for example, the 1% number. When you start thinking about it, that's pretty low risk. It's a very safe operation. But 1% of 2 million people a year is 20,000 people a year. So 20,000 people a year in the US get an infected joint replacement. Okay. Well, it doesn't sound like a big deal. Just take some antibiotics. It's actually a much bigger deal than that. For the knee, for example, 1 in every 10 infected knee replacements end up with an amputation. 1 in 10. Right, so that there's 10,000 infected knees every year in the U.S. Okay, that's 1,000 amputations for a procedure that was elective. This procedure is not life-saving. It's for pain. Okay, pain and mobility, and yet 1,000 people a year in the U.S. end up losing their leg because of an infection. So preventing infections is really important. Blood clots. Preventing blood clots is important because some blood clots go to the lungs, they become embolism, they kill the patient. That's bad too. Revision. Revision is where the surgeon has to go back and redo the surgery because the implant got loose or a part failed, or it's rework, basically. From an engineering perspective, you can think of it as rework. And that's bad too. Patients don't want rework. They want one joint replacement that lasts them to the end of their life. They don't want to come back for another surgery. Okay, so revision is an indication of poor quality. Dislocation happens in the hip, not the knee, and it's basically when the head of the implant pops out of the liner in the acetabular cup. And then readmission is something patients don't want to get readmitted to the hospital. They don't want to bounce back in to be readmitted to the hospital after the surgery. And between 4 and 7% of these hip and knee replacement patients end up back in the hospital within 90 days. So quality improvement is really about reducing all of these bad things that happen. Okay, and that's my mission. So let's talk about the structure of Marquee just a little bit. Well, first of all, I joined up with an orthopedic surgeon named Brian Hallstrom. He's on the right here. And we created Marquee back in 2012. And we proposed to Blue Cross Blue Shield of Michigan, the major health insurer in Michigan, to fund this activity. So it's funded by Blue Cross Blue Shield of Michigan. And the purpose, the mission of Marquee is to improve the quality of care for patients undergoing elective hip and knee replacement procedures in Michigan by sharing best practices among collaborative members. I want to focus your attention that it's about the state of Michigan. It's not about the University of Michigan. I'm faculty at the University of Michigan, but this is about the state of Michigan, okay? And one of the things we really made an effort to do was avoid University of Michigan branding and colors. You will not see any maize and blue block M on this slide, which the University of Michigan uses to brand everything. This is not about my institution. This is about the state of Michigan. Okay. Now, let's talk about the state of Michigan. So here's a map of the United States. Okay. And what's colored in red is the state of Michigan. So we're this little state in the upper Midwest that's divided into two pieces, what's called the Upper Peninsula and the Lower Peninsula that's separated by water, the Great Lakes. And we have about 10 million people as a population in the state of Michigan. So we're not a big state. We're not Texas. We're not New York or California. Just a kind of a medium-sized state in the upper Midwest. But in our little medium-sized state in the upper Midwest, there are about 32,000 total knee replacements done every year, and about 18,000 total hip replacements done every year in the state. Okay, so that's kind of the volume of procedures that we're talking about in the state of Michigan every year. We have recruited 67 hospitals to participate, which is almost all the hospitals that do hip and knee replacements in the state. It's not all the hospitals, but it's almost all the hospitals. We have a database that has data on patients. We'll talk about what data we collect in the next couple of slides. And our database has over 350,000 surgical cases in the database. So we have a lot of data to work with and to analyze. So here's the basic model. Blue Cross Blue Shield of Michigan pays for all the data collection, but it does not own the data. The data comes to the University of Michigan. And Blue Cross does not ask for the data at the patient, provider, meaning surgeon, or hospital level. They've never asked for that in an identified form, and we would not give it to them. And the reason is that hospitals and surgeons are really scared of insurance companies, and they're really scared that the insurance company will use this data against them to harm them financially. And Blue Cross knows that. They know as soon as they start mucking around in the data, the whole thing will blow up because everybody's too scared of them. So a big part of what we've been doing is really about trust building, honestly. So part of that is it's a non-punitive model that Blue Cross has vowed, and they've been good to this since we started in 2012. They've never used the data to financially harm any provider or hospital. Okay, it's non-competitive. The data that we generate and we share should not be used for competitive purposes. It's confidential. At our in-person meetings, when we come together, and Zoom meetings, what's said there stays there. And people have to sign confidentiality agreements saying that what's said there stays there, except to the extent that it's to be used for quality improvement back at their home institutions. Okay. You'll see that some of my slides have been fuzzed out. And the reason for that, parts of it is to protect the anonymity of our collaborative participants. We have 3 meetings per year. Before the pandemic, they were in person. Since the pandemic, they've been virtual. In February, we're going back to in person, hopefully. And at these meetings, we review data, share best practices, and prioritize our work. So what kind of data do we collect? Well, we collect data on 100% of the qualifying cases performed at these hospitals. A qualifying case is an elective hip or knee replacement procedure. We collect data on all of those that happen in the participating hospitals. Now, that means we collect data on 97% of the hip and knee replacement cases in Michigan. We lose the other 3% because there's some small hospitals that don't participate, okay? I'd like to get all of them, but we get 97%, which is pretty darn good. We collect data on bad things that happen to patients in the first 90 days after the operation. Joint infections, blood clots, things like that, medical events. But then the rework, the revision surgeries, we collect data on indefinitely because some of those happen years later. So we collect data on those indefinitely. And we collect data using manual data abstraction, trained data abstractors who are at each hospital on 257 data elements for every patient. We also collect some data through administrative procedures on comorbidities, and we link those together. The other thing that's really important is we can link data across hospitals, because often what happens is a patient has a surgical case at one hospital, but then things don't work out well for them, so they don't want to go back to that same hospital. So they go to a different hospital for the rework. Well, we need to connect those so that we know that the hospital that did the index or initial procedure, that they get linked to the fact that there was poor quality for that procedure that went to some other hospital. And we're able to do that. We can link data between hospitals. That's really important for what we do. So here's a picture of one of our collaborative meetings. About 200 people attend the meeting. The kind of people who attend the meeting are orthopedic surgeons. One surgeon from each hospital has to attend each meeting, and a quality administrator, as well as our data abstractors that we train and employ to collect data at the hospitals. And up at the front, you can see my collaborator, Brian Hallstrom, giving a presentation on the main screen up there. Next to it, you see a second screen. Well, what's that second screen about? It is where we present a conflict of interest disclosure slide. Now, I just clicked through my conflict of interest disclosure slide at the beginning of this talk, and you just saw it once, and then I went past it. At our in-person meetings, it's up throughout the entire presentation. So, for example, if a surgeon has developed an implant with a company, and they get royalties from that implant, they make more money personally by increasing the sales of that implant. And they stand up there and they talk about that implant and talk about how great that implant is. Wouldn't you also like to know that they're getting money that's related to the sales of that implant, so that you could appropriately throw the proverbial grain of salt on what they're saying so you can calibrate how much credibility you give that speaker? Well, to the side, on the side screen, it says whether they're getting money from that company. Okay, so for me, my slide says I don't have any financial relationships, which actually increases my credibility in talking about some of the things I'm going to talk about today. I'm going to talk about specific implants and medications. And I don't financially benefit from any of those. And the whole audience knows that. So let's talk about some of our successes. Let's begin with the first quality improvement initiative that we did. It started in 2012, which was making sure that blood transfusions is done appropriately. The patients who need it get it, and the patients who don't need it don't get it. And the reason why patients who don't need it shouldn't get it is because it's associated with risks of disease transmission, infection, death, being perioperative mortality, and longer length of stay in the hospital. And each additional unit of blood that they get, increases the risk of all of these bad things happening. So patients who don't need a blood transfusion, if they get a blood transfusion, all they've really done is increase the risk of bad things happening. Now, it's also really important to note that some patients do need blood transfusions, and they should get them. We are in no position and have no desire to tell physicians not to do things. We have no power to prevent anybody from doing anything. We have no enforcement or no enforcement incentives whatsoever, okay? No enforcement power. And that's really important. Everything is voluntary. But we really do want to encourage surgeons to only transfuse the patients who need transfusions. So this was our initial quality improvement initiative. So this is what happened with transfusions over time. And blue is the percentage of patients that are having hip replacements to get a transfusion. and red is the knee patients. And what you can see is there's dramatic reduction in transfusions over time in Michigan. This is across the whole state of Michigan. We also collect data on bad things that happen to patients that may be related to transfusions. So, for example, heart attacks. So if we were to see the rate of heart attacks going up, we would stop this quality improvement initiative because we don't want to create bad things as an unintended consequence. So we're doing that surveillance. I'm not going to show you the surveillance graphs, but none of those bad things have happened. The only thing that's happened is the transfusion rate has gone down without any increased risk of the bad things that could happen from not getting transfusions when you need them. So how did this work? How do we do this? Well, we abstract data on every case to whether there's a transfusion happens or not. We put that into a database, we analyze the data, and at the collaborative meetings, we present slides that look like this. This is the kind of slide that we present at the collaborative. And the fuzzed out part here, I promised you some fuzzed out parts. The fuzzed out parts are the hospital names. The people in the room get to see actually the hospital names. It's not fuzzed out for them. But I said, what's said there stays there. So my commitment to the collaborative is I will not share their hospital's data with people outside the collaborative. And frankly, people in Tehran, Iran are probably outside the collaborative. Okay, so sharing it with you would be definitely violating the rule of sharing it outside the collaborative. So I fuzzed out the names. But what you can see here is the two bars, the dark bar is the 80% confidence interval, and the slightly lighter bar is 95% confidence interval. And the left group that are shaded, the bars that are shaded brown, are the ones with the 80% confidence interval entirely overlaps the collaborative average. They're statistically, loosely speaking, the same as their average hospitals. The green bars, the ones with the 80% confidence interval, are entirely less than the collaborative average. These are good hospitals. And the orange ones that are entirely greater than the collaborative average are the bad hospitals. And I gotta tell you, you put this graph up there and the people in the orange hospitals, they pay a lot of attention, okay? So they're like, uh-oh, we are transfusing more people than everybody else is. We gotta ask, why are we doing that? And then they look at the green hospitals and go, what can we learn from them? The whole thing about what we do, the collaborative, when you see the word collaborative, the collaborative part of what we do is we bring people together in a data-driven format so the people who are performing really well, the green hospitals, can share their best practices with everybody else, which can improve the brown hospitals as well. They can get from average to better than average. But most importantly, they can help these poor performing hospitals improve just by sharing best practices. And it's data-driven. So this isn't just arm-waving stuff. They can look to see this is our actual data and how we're performing. So let me tell you the story about one of these hospitals. One of these orange hospitals, one of the clinical champions, one of the orthopedic surgeons at the meeting is named David Markle. And Dr. Markle, after seeing this presentation, went back to his hospital and convened a meeting of all the orthopedic surgeons who did hip and knee replacements at his hospital. And they reviewed the cases from the last 6 months and evaluated whether all those patients needed transfusions or not. And they realized a lot of them actually didn't need the transfusion based on their clinical scenario. And they realized they were over-transfusing patients. So they've just recommitted themselves to the Red Cross guidelines, which are really simple. The Red Cross guidelines says, don't transfuse a patient who has a hemoglobin greater than 8 grams per deciliter unless they need it. If there's some medical reason, like they're really at high risk for a heart attack, right? If the clinician feels they're high risk for a heart attack, you give them the blood. Nobody's preventing them from giving a transfusion. But the guidelines suggest they have more than 8 grams per deciliter of hemoglobin, then you probably shouldn't transfuse them. And if you do transfuse, just give them 1 unit of blood, then wait and reassess and give them a second one, only if they need it. Simple guidelines. They recommitted themselves to that, and this is what happened at their hospital. They went from transfusing 15% of their patients before this intervention to 5% of their patients. They cut it by 2/3. Okay? And more importantly, for those patients who had a hemoglobin preoperatively greater than 8 grams per deciliter, they've been, of those patients who are getting transfused, 35% were in that group. Okay, this is patients greater than 8 grams per deciliter. That went down to around 10%. This is the real benefit. These are the patients, a lot of these who were getting blood transfusions who really didn't need it. Okay, and just putting them at excess risk of bad things happening. Now, one reason I tell you the story is because you're very sophisticated people, and you know that just because I show you a time trend doesn't mean I caused it. Right? The old Latin phrase, post hoc ergo propter hoc, after this, therefore, because of this. We all know that's a fallacy. Just because something happened, changed after I did something, doesn't mean I caused it. But this is the important part of the story from David Markle. He said, our hospital information systems are so dysfunctional. We never knew we were transfusing this many people, and this many people over 8 grams per deciliter. Okay, we had no idea. I had to come to your marquee meeting to see how my hospital was performing to go back and motivate me to change. He said, it is because of Marquee. We would not have made this change without Marquee and Marquee data. So that's my argument for why we have a causal relationship to this improvement in performance across the state. Now, if we look at another measure, okay, related to a different initiative that we have been promoting about preventing blood clots, again, you see a reduction in the risk of blood clots over time, okay? And another one is the utilization of nursing homes. Patients can go home after surgery, or they can go to a nursing home. Now, some patients need extra nursing care, without a doubt, and they should go there. But nursing homes in America have a lot of bad microbes that live in them, and ones that can really harm patients, particularly methicillin-resistant Staph aureus, MRSA, is a really bad bug that lives in nursing homes. And as a patient, it would be better not to go expose yourself to that infectious agent and just go home instead. So we've seen this dramatic reduction in discharge to nursing homes. Now, what about costs? I'm motivated by improving quality of care. I'm not really driven by reducing costs. I mean, I really care about quality, but I can tell you Blue Cross cares about costs. So when I started Marquee, I did a cost savings exercise estimation, made a mathematical model, used all the things I know from capital budgeting, and made some assumptions, and came up with this black line that projected that our net savings would become positive in 2020. Okay, that we would cost them more to operate than we would save them, okay, up until 2019. That's why this curve is below zero. It would cost them more than they save. And then it would go positive after that. What actually has happened is in green, that we started saving them more than we cost them back in 2016, and it has just continued this linear trend upward. I made this graph back in 2017, but it has continued, and we now save the net savings is now over $30 million a year for Blue Cross. So what we've shown is it is possible to simultaneously reduce the cost of care for hip and knee replacement patients while simultaneously increasing the quality of care. It's a win-win situation, both in terms of cost and quality. It is possible to do. So now let's turn from just sort of like trying to convince you that Marquee, will tell you what Marquee does and that it's effective and it works. I want to turn to the part that may resonate a little bit more with industrial engineering audience, which is kind of the nuts and bolts, analytical issues. And the methods that we use is descriptive statistics, confidence intervals, regression, logistic regression. Now, that's all kind of stuff that I'm sure is taught in your undergraduate curriculum. It's commonly taught in all U.S. undergraduate industrial engineering programs. But we also use methods from biostatistics like survival analysis and Kaplan-Meier estimates of time to revision, Cox proportional hazards modeling. There's strong connection over to reliability engineering, and I'm not sure if that's in your curriculum, but actually a lot of the survival analysis in healthcare has its origins in engineering reliability analysis, okay? So there's really definite crossover between engineering and healthcare there. Also, statistical process control charts. We use in manufacturing settings, people talk about the fraction non-conforming for parts. For us, that's the proportion of patients that have a particular adverse event. And we use those charts all the time. We also use the Q-sum chart. The Q-sum chart has been adapted to healthcare. It's a little bit different than manufacturing, but it's very, very useful. And we find it extraordinarily helpful in what we do. And then there's also funnel plots that have been developed that you see on the right here. For the lower one on the right is the funnel plot, and the upper one on the right, by the way, is the healthcare Q-sum chart. So we use these a lot, but these are really very straightforward sort of statistical methods that have been developed in quality and mostly in engineering quality control, quality improvement, and then transported over to healthcare. Fairly traditional. Okay. Nothing really novel there, but I just want to let you know that we use all of these industrial engineering techniques and tools in what we do. But our primary analytical challenge, this is kind of the knowledge gap, the challenge that we're facing, is causal inference, right? Standard statistical dogma says you can only draw causal conclusions from randomized experiments. In healthcare, we call them randomized controlled trials, or RCTs. But it goes back to R.A. Fisher, the father of design of experiments. That you need randomized experiments to draw causal conclusions. But we don't do randomized control trials. We don't do randomized experiments. We collect data on how patients are being treated in Michigan and try and tease out causal relationships. You need causal relationships to do quality improvement. You need to know that A causes B if you want to improve B. If you want to affect B, you need to know what causes B. And if A causes B, then you know how you can manipulate A to change B. You need that causal information. But it's really hard to get it because there are all kinds of things that can mess up that causal relationship, particularly what's called confounding. So the area of causal inference has sort of been a convergence of research from different areas in the 1980s. Judea Pearl in artificial intelligence, Jamie Robbins in biostatistics and epidemiology, Rubin and Rosenbaum from statistics, and Clyde Glyamore in the philosophy of science. And that's sort of working very different fields. They sort of converge to this field now that's called causal inference. And if you want to learn more about it, I really recommend Judea Pearl's book, Causality, Models, Reasoning, and Inference. It's in a second edition at this point. It's a pretty dense book. It has its own notation and but if you're interested in this, it's worth reading. It is really a great book to introduce you to causal inference problems. But I also point out that, at least in the United States, these methods are generally not taught in industrial engineering. And at the end of my talk during the question time, I'd love to know whether your curriculum has these methods in it and where it is, because we could learn from you. Because we have so much to pack into the engineering curriculum. We've had a hard time figuring out where to squeeze this in. And yet it's really important for people to go into healthcare. I'm also going to point out that while back in the 80s, causal inference was very controversial, actually, because classical statisticians said you can't infer causality from observation data. It's just dogma. You can't do that, right? That's the standard statistical view. So it's been very controversial for a long time, but it's become much more and more mainstream. So, for example, I think about 2 weeks ago, the Nobel Prize in Economics was given to 3 economists who've been using causal inference tools in economics. There was really a Nobel Prize for causal inference. So it's become much more mainstream over time. And certainly in healthcare, these techniques have become more widely adopted. So let me give you an example of this in total hip replacement, in our hip arthroplasty. One of the things that we do is we present data by product name, by the name of the implant, of how it performs in terms of revision risk. And this is basically 1 minus the survival curve. And the pink is the implant, and the blue line is all other implants. You can see this implant, the Secure Fit Trident, has an elevated risk of revision. Whereas the next implant, the Trilike BPS Pinnacle implant, has a much decreased risk of revision. Basically, the Trilike BPS Pinnacle is better than the Secure Fit Trident. This is a quality measure, okay? And we present this publicly. We put out on our website information about the quality of implant by implant product name. And the purpose of this is to help surgeons select better implants. And surgeons are across Michigan are telling me they're using our data to switch implants to better implants. But the challenge here is, and this, I just sort of danced right by this. I kind of made it sound like it was easy to know that if you just switch implant, that the revision risk goes down. But that supposes I know the causal relationship between implant and time to revision. It implies this causal model. You select a different implant, you get a different time to revision. Okay, that's implicit in what I've just been telling you in the last 30 seconds. But the reality is a lot more complicated. Because confounders, for example, sex can affect the selection of the implant, because sometimes surgeons will select different implants for women than men. And also sex affects things like bone quality and other factors that affect time to revision. So sex affects both the implant, the exposure, and the time to revision, the outcome. And that's the classic definition of a confounder. So now you got to start dealing with confounding in your models, and there are ways to do that. But it's not as simple as this. If it was simple as this, life would be easy. The causal diagram for hip revision looks more like this. That also includes variables that aren't measured, like bone density. Okay, so the causal inference problem becomes really quite complicated, and we need to use tools that were developed in the causal inference world to draw our conclusions. And it gets even worse. That was simple. It gets even worse because if we look at blood clots, and we've done work on reducing blood clots, we've published 2 papers on different methods of preventing blood clots, aspirin versus other more expensive chemotherapeutics. And when I sat down with an internal medicine doctor to figure out the causal diagram for blood clots in hip and knee replacement patients, this is what we came up with. That's our causal model for blood clots and exposures for different chemotherapeutic agents. So drugs, basically, drugs and medicines. So it's complicated. It's really, really complicated. And that's our big challenge, is to sort out all of the confounding that exists in observational data to mitigate bias in our statistical estimates, so we can know how to manipulate certain variables to improve patient outcomes. Which brings me back to what I'd like to sort of finish up with to throw out at the audience here, because many of our graduates at the University of Michigan are in industrial engineering going into healthcare. And they don't analyze randomized data. They don't do randomized control trials. They analyze observational data. That's very widespread. But yet, we don't teach them these observational data analysis methods like causal inference. And I'm really curious what you all are doing at Sharif in terms of educating your students with analyzing observational data, not randomized data. So I'll finish up and then hopefully open the discussion for questions and get some feedback on that question that I just posed. If you want to know more about what we do, please go take a look at this paper on Marquis that was published in the Journal of Bone and Joint Surgery in 2018. Keep it up for just a second so you can write that reference down if you want. It's 2018 in volume 100. And also go to our annual report. This is a great place to find more information about what we do. The way to do it is go to our website at www.ebarcqi.org and pull down the tab, look for the tab Marquis Annual Reports, and you will go to a page that allows you to bring down PDFs of our annual reports, and they describe what we do in great detail. And I want to finally acknowledge my wonderful co-director, Brian Hallstrom, an orthopedic surgeon, as well as our project manager, Take Kim, and the people at Blue Cross who help fund our program, Monica Whitted and Mark Cohen. And with that, I'll say thank you.